I'll take that as a yes. Fantastic. Well, there we are. All right. Thanks for coming. Thank you, David, for organising this. So, David, and got some students here as well. Got a few more coming. Text them all. One more coming. All right. So, what we'll be doing tonight is just have a little chat about clinical Pilates. You all heard about it, haven't you? At some stage. It's everywhere. Have you noticed? Everywhere's doing Pilates. But the good thing is we've been doing this for a long time, and it's taken a while, but now it's sort of coming around, which is going to be terrific for physios. And we did start it with physios here first 37 years ago. Actually, Ad, can you pull the door across? There's still got clinics running out the back. Oh, my beeper's stopping working. I love it when technology works. Right, bear with me. Hello, Zhu. Thanks for joining. All right, get the screen running again. There it is. Come to there. Share screen. Great. So, as I said, we sort of started the clinical Pilates side of things about 37 years ago. Originally brought it to Australia back then. We set the first clinic up in Paran Sports Medicine. So working with athletes and sports people there initially, and dancers, which is where it started. So we've kept the clinical Pilates in physio practice. We sort of went down that track and thought, no, we'll stay with that. And I guess the big thing is how you use exercise as treatment. This is the thing we're going to be talking about tonight. What makes you as physios different from a gym instructor or a Pilates instructor, which is critical. Also, what we're doing with musculoskeletal sports and also neuro. We're doing a lot of work in neuro with this. At the same time, we've got a couple of postdocs on board at the moment to look at this because we're doing stuff with strokes, TBIs, and other neuro cases. And I guess the big thing here is translational research. Jason Q. Thanks for joining, Jason. We'll just keep moving. So it's translational research. We've all heard about research, evidence-based, nice idea. If it doesn't translate, it doesn't work. And that's the big thing of how we actually translate evidence into practice, which has been, how do you translate machines working into practice? Oh dear. That was me. Yes, 35 kilos ago, mate. I actually first came across Pilates when I was a dancer. I was with the Australian Ballet for 10 years, and that was years ago. And we started doing Pilates back then as a dancer, and I forgot about it when I'd left. But there was a chap, an orthopedic surgeon from St. Francis Hospital in San Francisco back in the 80s, who was talking about dance injuries, and he mentioned Pilates, and I went, oh, we used to do that. Anyway, cut a long story short, a guy called Jim Garrick, orthopod, way ahead of his time. He said if our high-level athletes, and we were working with the Lakers at that point, he said if they could do half the thing the dancers could do, they'd have less injuries. Turns out he's correct. So this is it. It's sort of everywhere at the moment, Pilates. It's taken a long time catching on, but what's a physio's point of difference? I guess that's the biggest thing to say, how can we stand above the noise out there? Things have changed. From when we started back in the 80s, I won't tell you, used to have a fag in the tea room at the hospitals, no problem. Back in the 80s, that was the respiratory wards too. Unbelievable. Miss those days. But, things have changed and continued to change in practice over years. The biggest thing we've got coming as physios is that the highest cost in the entire health system, have they told you this? It's musculoskeletal. More than cancer, more than heart disease, more than strokes, all put together, and mental health, all put together, musculoskeletal is the number one cost year in, year out. So what were we, 2018, 19, 11.5, 2021, 14.6 billion. We're about 3 years down the track. So, yeah, huge amount of the budget going on, predominantly musculoskeletal. But this is where we're spending our time. You know, how are you going to get better outcomes? And this is the thing, demonstrate your value. Don't waste money, don't waste time, don't over-test. And, you know, those confusing patients, how quickly can you make them clear? And usually the more confusing they are, the more clear they actually are. We'll show you something. And this is the other thing, solving problems, not just treating pain. This is part of the whole model of, do we just treat pain or do we actually resolve the problem behind it? This is the cost dollar we look at in healthcare. 80% of people take up 20% of the money down here. They're the ones that get better easy, give them a few exercise, a little bit of poke and hope and that sort of stuff, and they feel better quickly, good, they don't come back. It's the ones at the top where you've got a small group taking up a large amount of the funding, and even this smaller group up here, 5% taking up 50% of the funding, and these are the chronic complex ones, and these are the ones that we're looking at. And as physios, start looking at yourself, because they're the ones that will keep you interested and engaged, working out what is actually going on. So what is the solution to this complex problem? It's not actually that complex. In fact, we do this. We're taught this, aren't we? As students, you're taught structure-based management. You know, shoulder tests for structure. How many are there? If I said around 200, there are. There's about 200 tests for shoulder structures. How many are actually valid? In fact, what is it, O'Brien's test? You know O'Brien's test for slap lesion? O'Brien wants his name taken off that test because he's been taken to task by Chad Cook, who's a professor in Virginia, saying, mate, it's bullshit. I've got a surgeon who I know is a professor of orthopaedics at Liverpool Hospital, Ian Harris. He's doing some double-blinded study on rotator cuff repair versus sham surgery. He hates surgery and he's an orthopaedic surgeon. He said, I hate surgery that's not necessary. So he's doing a double-blinded trial on patients to prove you don't need surgery on rotator cuffs. And he's not alone. There's a lot of this going on. But there's a point at which treating structure, it no longer works. You know, they're not sure about structures. Tendinopathy, they're not sure about either. You go through all the structural management, it reaches a point where you then have to do something out. And that's where your movement-based classification comes into it. Treating structure, doing surgery, continually treating the same structure and over, and you're not standing back and seeing something else. So this is where the NBCT comes into it. And then we can go back and decide on a structure, hypothesize, but there's a point at which you do not continue to treat structure. And that point, 6 to 12 months, stop, if not earlier. So in your acute phase, of course, you're going to treat pathoanatomy. You've done an ligament, you've gone over, it's sprained, it's blue. Yeah, you treat it, you know the time frame, 4 to 6 weeks, should be fine. So you micromanage structure. We know the tissue-based processes. We know how long it's going to take. But once they become chronic, we've got to change. We can't be just treating the one thing. You've got to go back and treat the whole system. How many of you already noticed when you talk to patients, they all tell you, my shoulder's dicky, I've got a bit of a back, and my hammy's gone, and my knee's dicky, or my ankle, it's all on my one side. Have you noticed it yet? It's the elephant in the room. You'll hear this from 80% of your patients. It's called comorbidities. But one side is the problem. I've been dealing in sports medicine for 35 plus years. Same side plays up. You go through whole football teams, we've done it. EPL teams, Olympic squads, normal people. One side, 80% of the time. So this is the big one to pick up on. Here's Thomas. Thanks for joining, Thomas. So we're going to be looking at this chronic, getting beyond the pathoanatomy, in fact, taking the pathoanatomy out. This is what's happening. People are saying, well, the surgeons are saying treating pathoanatomy is not fixing rotator cuffs. It's worth billions. Start looking at the rest of the system. What did I do before? Oh. Bear with me, people. I press that. Nope. That was you, Thomas. You've come in and something's gone strange. It'll stop beeping in a minute. No. Sorry, people, just... It doesn't want to play. Sorry all, I'll just come back again. Got it. So once we get into the chronic phase, and again, 6 months, 12 months, that's well and truly chronic. Start looking at functional rather than structural. And again, this is where structural management then has to be taken over. And look at the whole system. As I said, not just one area, circle around a knee, missing the fact they've also got a hip and also got a foot, also got a shoulder, also got an ankle. And look at the whole system. And this is, we talk about whole person treatment. This is exactly what this is. How do we treat the whole person? It's called regional interdependence. And again, we're now looking back at the cause, not just the structure. And this is with knees. We see ACL. You can have an ACL reconstruction. How often do they re-rupture? They're getting upwards of 50% now. Very high. Chances of going back to sport after ACL, very low. And you can do just as well, if not better, without an ACL. So this is where structural management also runs into trouble. So, Pilates. So if we're going back to when Pilates started, the culture physique area, it was back in the 1930s, 1940s. It's a bit like Carl Benz had a good idea way back then, and it's moved on. We did start for a long time looking at transversus. You may have heard of that muscle. They buried that 13 years ago. Did you know that? 13 years ago, transversus was proven. WA, Sue Morris was one of the researchers. Gary Allison, professor of physio at Curtin University, buried it. 2013. Thomas, mute yourself. Thank you. No, you can't have that car. So the clinical Pilates, we started looking at transverse, then we started looking at other things with ultrasound. It's a bit like Mercedes has gone and had a good idea. Wouldn't mind one of those. But here's where Pilates being everywhere. And that's only one. I got some others. I tell you, spend 5 minutes on TikTok. Just go in Pilates injuries TikTok. And within about 5 minutes, I'll show you another couple I've picked up that are even worse. We're actually seeing a lot of people injuring themselves on Pilates. And this is where, in fact, every patient is different. You can't give everybody the same group of exercises and expect a good outcome. It's probably not time to tell you now, but whatever you hear from me tonight, repeat none of this in exams. Protocols are a waste of time. Do not do protocols unless you're told to. Then once you're doing it. Because every patient is different. Protocols are generic, aren't they? Major problem. You've got a 70% failure rate, about 30% success. So, every patient is different. We've heard that, haven't we? Oh, I've just told you. What's that difference? It's 4 words. It's their response to directional load. That is what's different. And this is in fact what we've now proven with research. We've got PhD. We had another course in Singapore on the weekend. One of our PhD researchers there. We've proven this. We've proven this. It's not a great big long story. It's the directional response to load. That's it. That's it. You all know what a kappa is, don't you? You know what a 0.87 kappa is? It's called near perfect. High inter-rater reliability. That's 0.87. Look it up. Haven't they taught you that in research? How good's the research? There's a lot of crap research out there, trust me. And this is the thing, look at directional preference. Looking at stuff on muscle, like your transversus and all the rest of it, it never reached good levels of evidence. Never reached level 1 evidence, that's for sure. But the model of direction, centralization, has continued for about 20, 30 years. this idea of a different direction gives a different response, has persisted. And this is what's being missed. As I said, translational research. What we do all too often, you make an observation and come up with intervention. You know, stiff joint, loosen it up. Have you fixed them? No. Goes stiff again, doesn't it? Flat tire, you pump it up, it's going to go flat again, isn't it? Because you haven't fixed it. And this is the thing with treatment. This bit in the middle, what's actually the problem? Sort the problem out and then come up with a better intervention. You know, a flat tire that keeps going flat's got a nail in it. Got to fix it. A stiff joint that keeps getting stiff, it's not the joint. What's the neural response there? And this is where we've got to think at the next level. But look at this, Shane Watson, you've probably heard of him, good cricketer for many years, in and out of playing, shoulder, this was in the paper a few years back, shoulder problems, back problems, side, groin problems, a happy birthday hamstring, calf problems. You know, you look at his injury list and there it is. It's all on the same side. He hasn't got 1, 2, 3, 4, 5, 6, 7, 8 different structural problems going on. He's got a pattern of problems. And if he gets a next injury, where do you think it was? Left side or right side? You're a genius. It's almost too often. You know, we sort of sit there and go, oh, look, there's a couple of little tire fibres and pectineus that look a bit damaged. We don't look at radiology much anymore. Maybe for big, nasty things. Yeah, that's about it. But aside from that, the false positive, false negative rate, very high. Yes, it looks like a disc, smells like a disc, behaves like one, treat it like one, gets better. Good. It was correlated. But with things like this, we can't be looking at them doing surgery on all these different areas, expecting them to get better. And you'll start noticing this more and more. There's something going on. In fact, it's a bit like this. A bit weird, isn't it? How much detail's in that? Take some of the detail out, blur your eyes, stand back, and you've got Sigmund Freud. That's what we want you to see, not all the detail. And this is the moment in your structural models, everyone's looking at the little tiny detail and missing the big issue. We get distracted. So what's different? What's clinical Pilates all about? And this is it. We're looking at function over form. And better function does give you better form. At the same time, people have had structural management and it hasn't worked. And it's not homogenous. It's not protocol driven. It's not everybody gets the same exercises. Every patient is different. This is where the heterogeneity comes into it. Can you subgroup your patients and get a better outcome? 0.87 kappa, look it up. Okay, so having done it for many, many years, getting good results, thinking, well, what is this all about? We started embarking on some serious research. We did a series of pilots first, and 2011, what's this, 14, 15 years ago, started looking at systematic reviews. This is Singapore General. We've been doing a lot of work in Singapore now for many years and still work with the hospital system up there very closely. But Edwin Lim did this as part of his PhD. It was better than doing nothing. Any exercise better than doing no exercise. You know, doing transverse is better than doing nothing. Yeah. But when you look at comparative, the p-values tell you there, not much difference. Studies weren't that great. Careful. Let's do some RCTs. So we did. We went and did an RCT through Melbourne University, and this was looking at comparing apples with apples. Clinical Pilates versus general exercise for chronic low back pain. We didn't have any acutes or subacutes. Randomised them. Only chronics, only delivered by a physio. We had a 14-year on average. That's chronic. That'll do. And universities get a bit nervous. Could be too chronic. Welcome to my world. That's nothing, 14 years. Looked at 6 weeks, 3 and 6 month follow-up. And then looked at your general exercise group, you know, basic explanation, giving some education, doing all the normal things that you do. And this is the problem with education, which I'll talk about in a minute. Unless you can demonstrate, don't bother to educate. Otherwise, it's just all talk. You show me the money, then I'm going to listen. But we still hear education is critical. I'm going to upset you. Don't repeat this in exam. So they did the same exercise. Everyone got the same thing, 6 weeks, diary. You know, put them on a bike, balls, these sort of things. We've seen all these sort of things before. The clinical Pilates group were different. They were subgrouped into this directional preference model. You know, some were better with flexion, some were better with extension, some to the left, some to the right. And even with the research, we had a fifth group in there which shouldn't have been there. They were non-responders, but I get left out when you start these studies because I'm what am I, the Rosenthal effect or the Hawthorne effect, one of those. They don't want me there. So same thing, 8 to 12 exercises on equipment, twice a week for 6 weeks. Exercises like this. So, thing called knee stretch. But if you look at the force vector in that, the load is extension loading. This one here, that's also an extension loading on the left. So we don't do these on both sides. Just said, most sides are on one problem. Don't treat both sides. Tattoo that on your arm. We've now proven it. One side. And the side we're treating is the moving side, not the static side. These two exercises, these are both flexion exercises, and if you're treating a patient, you won't be doing the flexion exercises in the same program as the extension exercises because of provocation, and this is where you can then decide pathology. Now, if you've given this to somebody who actually does have a frank disc protrusion, you're going to make them better or worse? You will make them worse. If you give this to somebody who's meant to have a spondylolisthesis, could you make them worse? What if they get better? You've got a radiological false positive. Doesn't correlate. And this is your job. It's going to become determining radiological findings. We're the only group that do it. Nobody does it. Surgeons don't do it. Doctors don't do it. Sports physicians don't know how to do it. We're the only ones that test underload radiology. At 6 weeks with this, both groups got better, so exercise is better than doing nothing, P001. Low level of dropouts, which was good. Your general group got 29%, your clinical Pilates group got 46%. So there's a measurable difference between those two groups. And baseline adjusting, there was still better numbers from the clinical Pilates versus your general exercise at P07, which is pretty damn close. Except there was a fifth group that shouldn't have been there. We take the fifth group out, researchers get upset. I'm just a clinician. And you go, smashed it. But they're effective, but the grouping on the subgrouping group did better. Now, where did we get the subgrouping model from? Panjabi, back in 2003, looked at this idea of neutral zone. They talk about neutral spine. There never was a neutral spine. It was neutral zone. It's a term that became popular, but there isn't a neutral spine. Because in neutral, nothing actually happens. I'll show you that in a minute, actually. You've got to move. So Panjabi had this model, end of range extension, end of range flexion, but where you spend most of your time is in the middle. You know, that's end of range flexion, that's end of range extension, but you spend most of your time around the middle, don't you? And he got this idea, in fact, looking at displacement by muscle, difference between load and displacement, and this idea of a ball in a bowl, where it moves most of the time, which is looking between flexion and extension. We took this one step further and said, we've got flexion and extension, so turned it into a true 3D bowl. You've also got a left and a right. And therein was the hypothesis. Could we prove this, that you could categorize people into one of these four segments reliably and have a predictable outcome based on Panjabi's work? And the good thing is we can say yes. So, some people are better in flexion. Some people are better with extension. Some people have more problems on the right, more problems on the left. So a unilateral, unidirectional approach is giving far better clinical output than what we see on a protocol where both sides are done, even though there's a strong asymmetry. They're doing things in flexion and extension. So we looked at this through the Otago University, which was looking at the reliability and predictive validity of this. That was 2012. And this looked at dynamic stabilisation. How high can you jump and then land, but then measure on a forced platform to see time to perturbation, time to stability with perturbation. The nice bit with that, shorter the time to stability, the better. The longer, the poorer. So this is stability. I hear the word stability all the time, and then I ask for the explanation, and it just doesn't make sense. Yeah, core stability, you know that word? If I hear anybody use that term, there'll be tears. It's a whole industry of people who are flatulent, incontinent, dysfunctional, this strong core thing. Please don't use it. I've been treating strong, well, there's one over there, a study we did, British and Irish Rugby Lions and the Royal Ballet. Now, it couldn't be two more different groups there, could they? So why have the strong guys got more injuries? Who are the two teams this year up their strength and conditioning? Was it Carlton and Essendon? They've increased their strength and conditioning. Who are you barrack for? Bad. Every year. The more strength work they do, the more injuries they get. Not just in Australia. This happens a lot. Now, going back to dynamic stability, which is movement control, and this little study was looking at baseline tests, time to stability, how high can you jump and then land, and control it. So 4 exercises with a matched bias, as we call it, matched their directional preference. Reassess, they were better. The predictor was the same group do the wrong exercises on purpose. Reassess, they were worse. The second group, group 2, baseline testing, did the wrong thing first, they got worse. Did the right thing second, they got better. This is reproducible. None of the transversus stuff could ever be reproduced. I tried, lost my hair, got lots, hundreds of ultrasounds, you want to see them. Gary Ellison kept going, and he got to the point and said, yeah, you're right. It's crap. It's not a corset. It's actually a movement muscle. I've got one for you. Transversus, low back pain transversus, yeah? What's the nerve supply to transversus? What if I said thoracic spine, T6 to T12? There's the problem. No one picked it up early on. We picked it up and went, hang on, how can a thoracically innervated muscle be affected by lumbar? I'll leave that one with you. Ask the question, watch people go. But anyway, so this is where looking at patients. Can we look at their function? Can we look at their stability? Everybody's got one of these, haven't they? Except your 3-year-old. She hasn't got one yet, has she? No. We'll work on that. Keep her away from it. Everyone's got them. So this is where we're saying record your patients. If we look at a patient like this, as I said before, most patients have got an asymmetry. They've got one side that doesn't work. So this is why working both sides doesn't get the outcomes we hope for. Could you take a wild guess which side's the problem? No, you can't. It's not a trick question. Guess. Now, if you say weak glute, leave the room. She's done glute strengthening, hasn't worked. She's done a whole lot. It's been going on for 2 years. She's lined up for surgery. Doesn't want the surgery. Hip surgery, labral tear. There's another structure that has been banned. But if you can take this patient, let me define they're going to be better on the right side, just doing extension. So we're reassessing the same patient on the same day, on the same test, post a unilateral unidirectional intervention. Is there a difference? Is it measurable? Is it recordable? I don't write letters to surgeons anymore. I send them videos. Hey, they don't read your letters. But you show them a video. Is there a recordable difference? Now that's happening within session, within patient. We haven't strengthened the muscle. This is next level stuff. This is neural, isn't it? This is neural latency, muscular. That's what we're addressing. We're not addressing muscle strength. As I said, muscle strength is low level, dare I say, low level intelligence. Yeah, I'll get into trouble. But doesn't address the problem. Here we've addressed the problem. Same thing, you can record this. If we're scoring outcomes, we talk about it. Single leg squat, heel raise and a hop. Out of 5, she scored herself 73% function on the left. And you wouldn't argue that she scored 33% function on the right. So we've got a 40% asymmetry index. Post-intervention, 3% difference on the left. Now, not significant. A 37% change on the right is significant. Does that patient need surgery? No. And I'm getting old and grumpy now, and I deal with a lot of young surgeons who go, this is not a surgical candidate. And that's objective measure over the opinion they need surgery. And if it goes pear-shaped in court, the objective numbers win. Remember that. I've had several of them, quite a few unfortunately, but that 37% change in function, I can say this is not a surgical candidate. End of story. So, and the patient goes home and looks at it and goes, yeah, maybe you don't need surgery. You've created doubt. And that's about $35,000 it's saved on one patient right there. So, give you an idea of how this works. This is her, Karen. She had an 18-month history of right glute pain and weakness, running upstairs initially, fell hard, push, and then a couple of falls on her butt since then, going to the gym regularly aggravated it. Also the right leg pain, not sure why, and recent hip pain. Bit of right and low greater than left low back pain, and also neck. So if you look at a body chart, you can see most of the problems are on the one side. So we know this is a one-sided problem. Currently considering a hip scope for the right hip, but there was questions. Lots of treatment, standard core stability, SI, joint mobs, prolotherapy, cortisone, massage, blah, blah. Hadn't worked. Now here's where the interesting bit comes. Bike riding made her worse. She was a triathlete. Getting out of the car, especially sitting cross-legged, walking upstairs and running. Is there a pattern there? What aggravates her? Flexion. Eases, swimming, walking, standing, pattern. And the last one up there, trauma. What was the trauma ultimately? Flexion trauma. That's an exclusion. Ags are an exclusion. Eases with extension is an inclusion. Right side is the problem, is an inclusion. This is how fast you can do diagnoses. It's called a heuristic. Saw her getting out of bed, sleeping in a fetal position on her right. She'd had scans, sacroiliitis, disc protrusions, labral tears, FAI, all that sort of thing. But you've got there a pattern of one-sided problems. And here's the algorithm right there. You only need 4 bits of information to make a decision. And this has been proven in the military, this has been proven in the airlines, this has been proven everywhere. Medicine somehow misses this by putting more in and confusing the bejesus out of everybody. So this 4-piece algorithm, what kappa's it got? 0.87 kappa, near perfect. Your body chart, left or right, where you got right, the eases, the things that make them better, they're an inclusion. So if we have a hypothesis of right side extension, Your ags then of flexion, your trauma there of flexion, their exclusions. These are hypotheses to then treat unilaterally and unidirectionally. It's been proven over and over now and getting stronger, which is fantastic. So this is where you run into problems with protocols, because protocols will mix those all up, won't they? So these are right extension biased exercises. So this exercise here, instead of doing it in the middle, you're going off to the side and just moving the right leg only. We've seen that exercise before on all fours. I warn people, if I ever see you doing that on both sides, I'll find you. I have friends. You only do it one side. Do not do it both sides. Unless you want to hurt people. And that's what's happening, unfortunately. It's stuffing people up. You support on a good leg and you move the problem leg, and that's an extension exercise. You don't give it to somebody who's had an extension trauma. Exercise here on the machine, hands off to the right, in extension, that's right extension. Knees stretch there, hands to the right. They all fit a right extension biased process. So those are the 4 exercises we did that made the change. These are an example of the exercises you wouldn't do with her. Even though they're right side, these are flexion. That's a flexion exercise. That is. All of those will make the patient predictably worse. So this is where we come down to how we make this work. If we're looking at a chronic patient, before we give them exercises, don't just put people onto a Pilates bed and give them a group of exercises. That's not treatment. You're physios, not instructors. So the treatment, 4 to 6 to 8 weeks, depending how long. 5, 10, 15, 20. I've got patients 40 years of problems. You're not even that old, are you? Is there an asymmetry index? And this, as I said, demonstrate before you educate. Don't just educate them. If you're just doing the talk, you've got to show the walk. Do that first. Like I said, that's why these are good. And then, now I'm interested. What is going on here? Your management phases is the next 4 to 6 to 8 weeks. You look at this history of comorbidities. Is there symmetry improving? And then finally we get into the maintenance phase. And this is, again, whole of life. I say to my patients, what do you want, holidays or hospitals? Us baby boomers, we want to be on holidays. We don't want to be in hospitals. The doctors want us in hospitals because they make money out of them. Let's send them on holidays. And this is, again, where they go into group class things. So this is the thing we hear, Pilates classes, Pilates groups. That's when it works, but you've got to do these other 2 phases. 50% of people, if not more, going to Pilates classes in gyms and studios have got problems and they're getting injured. Some of them badly. Discectomies, fusions, blowing out a big listhesis. So this is the thing we look at. As I said before, when you're taking a history from your patient, is get the whole body chart. I might have some pain there, pain there, pain there, pain there, pain there. It doesn't mean you've got 6 different things, Hamstring tendinopathy, Achilles. They're not convinced on that yet, are they? In fact, they're going to change the word tendinopathy to tendinalgia. Yeah, tendon pain. Because if you can change it quickly on those tests, what's the structural correlation? This is another study we've got running at the moment. Same with hips, same with knees, but there's a pattern there, one side. So your body chart shows a problem. In this case, it's right. We go through their easing factors, their ag factors. You keep the preference, you exclude the ags, you exclude the trauma. And that was the big one we found that gets missed all the time, is their direction of trauma. If you bend over to pick up a footy playing AFL and do your hamstring, that's a flexion trauma. And then we see a whole lot of stuff in their rehab involving flexion, and then we see a recurrence, and another recurrence, and another recurrence. So as I said, this is where it's being missed. So we can then look at the patient and say, okay, they've got the problem on the right, their preference is extension, that's our hypothesis. Do less, and you're going to know a lot more. If you just do a whole lot of mishmash stuff, you'll end up going, I don't know what to do, and the patient will go, and live. It's called a heuristic. This has been proven, as I said. There's a lot of information that you don't need, and you can make good decisions with very high accuracy. Don't throw as much as you can into biopsychosocial. Anyone use biopsychosocial? How do you use it? Ever seen a good RCT on it? No?
Well, I read one by
An RCT on biopsychosocial? I haven't seen one yet. I ask undergrads all this. In fact, it's outlawed, it's outridden because it's now the socio-psycho-biomedical model. What's the difference? Medical. They got upset, they got left out of it. So they threw that into it. In fact, biopsychosocial is very quick. The RCT can be done, and we're putting a thing together to show. First thing you've got to do is take the bio. If you can prove to somebody that the bio isn't the problem, do you think it's going to affect their psycho and their social? I'm trying to get a university to do it in Australia, but that probably won't be in Australia. I'll tell you where it's going to be. Can be done. And that's it. We take out a lot of information. We still can control the risks that we've got. And this is where we can then start classifying. So as I said, exercises, these two exercises are both left extension. I'm going to move them on a bit. So she's got, right extension on that exercise. Oh. There we are. This one is also extension, both hands moving to the right. So again, this is where I said movement comes into it rather than structure. You're moving them in this direction. This exercise here, this is a left extension. Next time you see this exercise, remember those words. I'll find you. Only left side. Left side of problem, left side moves. Exercise here. And here we've got left foot back, so non-weight bearing on the problem side. That's also left extension. So this is where the categorization comes into it. What am I doing? Oh, there we have some more. Top left corner there, that's a left extension movement. Side. Right leg. And we see everybody goes to a Pilates class and they're given this exercise. Now, if you've got a disc problem, you've got a flat back and you're putting load on it, could you provoke a disc problem? Yes, you can. And we see them and I get them, and quite often there may have been other problems at the same time, but this is the problem. You lie people on the back and half of them are going to respond badly. Half. And that's flexion as well. So they're all right flexion exercises. So this is part of what we've got to do. We've made our job very, very hard by trying to do everything. Do the opposite. Learn from history. Steve Jobs, Apple, most successful corporation on the planet, he made it simple. Gave people less choices and they bought more computers. So 13 years ago we had this. 15 years ago now, God. We've got more and more information, more and more knowledge, but still nothing that's getting better treatments. We want quick and dirty tests, matching treatments to physical predictors of response to treatment. And the nice thing is now we can say we have definitely done it. In fact, I'll show you something in a moment. We want to avoid stuff like this. This patient's been stalking me on Facebook. I sort of hope they don't show up. 18 revisions of a knee prosthesis. Do you think he's got a knee problem? The first thing I'm going to say to him is, I don't think your knee's the problem. 18 surgeries. We won't talk about cost. It's over $500,000 spent for a bad outcome. So he said he's doing well. Good, don't come here. You may turn up. Popping up over the last couple of years, started during COVID. But anyway. Okay, so this is some of the more recent research. There's been quite a bit of other stuff we've done, but this is Bun Chong Kwok from Nanyang Tech in Singapore. Nanyang Tech is one of the top industries in the world. It's number 12. Melbourne Uni's 19 and Sydney's 25. Someone asked me the other day, said, where is Nanyang? I said, it's in Singapore. It's double checked. I double checked it. Yeah, it's number 12. It's right up there. So this was looking at the single leg squat and also hamstring flexibility. So the little test that you saw before, how valid and how reliable is that? So BC's PhD was looking at the single leg squat as one of the tests to validate it. Had 40 subjects with chronic low back pain, looking at postural sway, and also depth and hamstring flexibility to determine the problem side. Also vertical peak force variance, and ultimately measuring on force plate with an electrogoniometer, finding your non-problem side pre and post intervention, which was one side, one direction, small improvement, but on the problem side between your pre and post, a significant improvement in the 40 subjects with a unilateral approach. Bingo. Feasibility, this was again last year, looking at non-specific chronic low back pain group. And what is the feasibility? Again, motor control. People talk about motor control. It's not cortical. It's actually subcortical. We're doing this stuff now with stroke, neuro patients, brain trauma, and it's actually not cortical because people can't control from their cortex, cannot control motor function. But we hear it, don't we? Think about the muscle. It's actually the opposite. I'll show you. Psychosocial doesn't consider function. This is where the bio component, so this is where this study is going to come from. It's going to come out of Singapore. It's being written up. So here's the big one. Again, another group of 40 non-specific chronic low back pain patients, and 100% of this chronic group could be individually classified with that model. Did that maybe just change something? This is about to blow the doors off the whole chronic low back pain research story. So if I disappear under a train, you'll know why. 100%. I said, guys, you're not going to publish this. People are going to go crazy. They're going to tear it. And they went, no, we're quite happy. 4 professors looked at this. And they went, no, we're happy with this. I said, let's do 400 and get it down to 96%. So, yes, the doors may truly be blowing off this stuff. This is going to be interesting. As I said, it's just come out. So looking at the classification system was feasible, and looking at case complexity. So we're looking at the chronics. It pretty much is number one, isn't the cost burden? You've heard that, haven't you? Low back pain. Here's your job. Your careers, not your jobs, your careers have just been put in place. Pain function, hip flexibility. After, again, looking at chronic low back pain group, 18 adults, subjective pain and function, objective hip knee strength and hip knee and trunk hip flexibility were determined. Again, they were given the individually biased exercises depending on their subgroup, and again, looking at the remeasuring within session. The remeasuring process is about 15 to 20 minutes from assessment, intervention, reassessment. Another study, we've got a post hoc analysis there. It's about a 27% change in function and proprioception. Better than anything else that's been done. Within session, within subject. That was one out of Otago. We haven't published that yet. So they had changes in pain, patient-specific functional scale, flexibility at P001, no change in strength. But people still focus on strength, don't they? And unfortunately, strength was just proven back in the 90s. Do they teach MEDEX, BIODEX, CYBEX, KingCom at uni? No, that was all peak torque isokinetic strength testing equipment, 30, 60, 90, 120 degrees per second. How much peak torque could you generate? It was proven late 90s, doesn't work. That's why you haven't heard of it. That's strength tests. Look them up. CYBEX, BIODEX, MEDEX, KingCom, they're just some of them. So, I don't know with strength. I get very confused. So again, MBCT and chronic low back pain. Another one. This was done a while back. So it's not just AP, it's also lateral. And this is again looking at gluteal clamshells. People use these all the time. We've seen this, haven't we? Biggest mistake is it's done on both sides. Only one side's the problem. And this study particularly was looking at directional. This is where if you've had a lateral trauma, it can be a big difference from having an AP trauma. Example of a lateral trauma, get T-boned in a car accident. Bang, it's a big lateral trauma. And unfortunately they became chronic, these people, because they're treated this way when their response to treatment should be lateral, not AP. So this again was looking at hand dynamometry, hip flexion of 30, 60 and 90. And again, on the non-problem side, glute med was fine and all angles. On the problem side, there was a significant dysfunction at 60 degrees hip flexion. They're now doing this with extension because that's the other thing that doesn't get talked about with this, whether it's a flexion or an extension. So the glute people are going to be after us too. Oh well, saves getting bored. I'm old and I don't care anymore. But this again is a big one. As we saw with that girl earlier on, is that a glute med problem? There was something going on, wasn't there? Which was addressed very quickly with the lateral. So again, dysfunctional side, clamshell, it's good for assessing this motor control coordination, and that's again part of another series of studies that we've got running at the moment. That's right, you're all undergrads, aren't you? Good. You know the rules. Don't repeat any of this in exams. We're going to teach you how to then break them, because you have to. Because you just don't have time. And that's why, as I said, to go through all the things you're meant to go through, you don't need to. And that's been proven as well. All right. Oh, yes, this is one I was going to show. This is another one. Straight off TikTok. This one's even a bit nasty. I mean, what is she doing? You idiot. This is not Pilates. This is bad. People are saying, I'm getting sent these, and people are going, oh, is this a Pilates exercise? You go, no! People are making shit up. And unfortunately, what sort of directional trauma was that one? Extension trauma. Yeah. So if this person's then given postural correction, do you reckon she's going to be happy? Nah. Yeah. So, like I said, 10 minutes on TikTok, see how many you find. I got a bucket load. Oh, I'll go and watch it again. You've just got to. It's just on a carriage. I mean, this is just madness. In fact, that almost looks like one of our machines. I didn't notice that. I hope not. Oh, no, it's not. Thank God for that. All right. Now we'll do some demonstration. Let me just turn that off. Anybody got any questions? Where's my group? Any burning questions from the group out there so far? Can you do chat? You can do chat. Zhao, how are you?
Yes, hello. Just a quick question regarding different organizations, different systems. So you created DMA, and then I'm aware there are multiple different organizations out there.
Correct.
Can you briefly tell us about what's the difference among each one?
The difference is the research, number one. We're the only group doing research based on a treatment model. We've been doing it the longest as well. The other programs out there are not focused on physio treatment, they're focused on gym instruction, to put it quickly. You'll hear things like transversus neutral spine still being used. Those things, Gary Allison, Sue Morris, people like that for one, stopped using transversus 13 years ago. It was proven incorrect. So there's a lot of old information in other systems. And again, when it comes to treatment, there's none being tested at this level. We've got some other papers. I didn't actually put them up there. Some papers that have been published out of the PhD in Singapore in the last few months. So that's probably the biggest difference, is that subgrouping model, and also the fact that every patient is actually treated on that model. So it fits in with clinical practice guidelines. Is that the short story?
Yeah,
Great. Okay. And if you want to do some research, come and talk to me. All right. Shares out of the way. Let's do some practice. Can everybody see us?
Sorry, I just had one more question.
Yeah.
How would you determine the dosages of the exercises?
With the dosage of the exercise, what you're doing, you're looking at high repetitions, low load. So this is ultimately you're sort of working on a endurance model. So that's why you'll be looking at, like any endurance program, 15, 20, 25 repetitions at relatively low load. So it's the opposite to the strength training model, which, as I said, strength training's been very poor at improving injury models when compared apples with apples, and the endurance model is far more. So that's why there's sort of fairly long dosages as opposed to max rep, 1RM sort of thing.
Got it. Thank you.
Okay.
Sorry, Craig, I had a question as well.
Yeah, yep.
Where would be the best place to get more information on this treatment model?
Well, what I will do after this is I'll put up some links to the research. So there's some on our website, but I can actually send out a link. Can we do that? Yeah. We'll send out a link to that research. It said this is going back sort of some 15 years. We did pilot studies before that with the Premier League in the UK, AFL, Australian Institute of Sport, English Institute of Sport. We've done a lot of studies on this. So yeah, they're all online. They're all published. Actually, there's quite a few that are unpublished, but that's another story because they were too effective. But yeah, we can certainly put the links up for you. If not, www.clinicalpilates.com. That'll give you the basic overview as a starting point. Yeah.
Amazing. Thank you, Craig.
Not a problem. All right. Now kick your shoes off. So I've got a little group of demonstrators here. I'm going to have a look in this group and see if we can find any asymmetries. Anybody got any problem? I asked that before, didn't I? Anybody got any injuries? Well, the other thing that we do differently with these training programs is we get a history on every participant. We do a screening form before they start so we know what we've got to see if there's any major problems. And they also become good case studies for the courses. There's no other courses through physio that actually assesses the participants, which is actually a bit naughty. Put that into one of the committees. I did mention it once and they went, how do you do that? And I went, easy, give me a sheet. Okay, what I'm going to get you to do is stand in front of me, David. All right, can we see that over there? Give me one hand, just lightly. Good. So you're going to stand on one leg for me. That's it. I'm just going to get you to do 5 little squats. Just go 5 and 4, 3, 2, and 1. Stand on the left leg. Go 5, 4, 3, 2, 1. Stand on the right leg. Just rise up on your toe, going up. I'll give you that one. Go 5, 4, 3, 2, 1. Left leg. Go 5, 4, 3, 2, 1. We notice anything so far? Okay, 5 big hops on the right for me. Go. 1, 2, 3, 4, 5. 5 big hops on the left. Go. 5, 4, 3, 2, 1. Yeah. Did they feel both the same, or was there one side a bit different?
Left a bit harder, I reckon.
All right. All of you, pair off. Just do those tests. I'm going to walk around and see if I've got anybody with a better asymmetry index than this. Let's have a go. So just get in pairs. I'll put you in pairs. There you go. 1, 2, 3. Done.
Right. So squat and then
So the aim of this test is one of the very basic tests. We can do upper limb function, but this is lower limb function. We can look at single leg balance. We can look at other tests, but this, just to see, is there an asymmetry index of any sort. So I'm going to find one, and then we're going to do something with it.
3, 4,
It's really the same.
Also depends.
Any big difference?
Not so much. I think I mean, it's just it was less of a difference.
Anything major?
Left squat.
I think my left glute, like after staying down for so long, just that much. Getting a bit tight.
I heard that. Sitting.
Sitting flexion.
What were you like?
Um,
I haven't done it yet. Okay, last test. Can they see you from over there?
sorry,
Just stand on there. Laura,
Oh,
go.
is it?
a squat.
In. 2, 3, 4.
Yeah, and you're right.
Now, high as you can. Go 1, 2. Go.
Again.
Yeah. 1. Out of you two, which side was worse?
Left.
Left side. Did we pick that up on the group? Stand just there for me. Okay, Laura's volunteered. Just go back a little bit. So I'm going to just give you in fact, I'm not going to, cross your arms. So stand on your right leg and just do 5 squats for me. Go 5, 4, 3, 2, 1. On the left side, go 5,
Oh,
4, 3, 2, 1. On the right side, rise up on your toe, going up, 2, 3, 4, 5. On the left side, going 5, 4, 3, 2, 1. About 5 big hops, high as you can. 1, 2, 3, 4, and 5. Left side, 5 big hops, go. And 5, 4, 3, 2, 1. Shit and shitter, but the left is okay, did we pick that up online? There's definitely a problem going on there. Both sides are struggling, but the left side is certainly harder to recruit, slower, and not working as well. So,
I could just feel that in both ankles. It was so bad.
have you got any injuries? I asked.
My left wrist, that's about it at the moment.
At the moment.
Well, I've sprained my left ankle about 10 times, but
Sprained left ankle about 10 times.
Yeah.
Left knee, any problems?
no, not really.
Right knee,
No,
left hip,
no,
right hip, any lower back,
yeah, just on that side.
inside,
And my neck,
and your left neck.
left neck,
What
yeah,
about your left shoulder
yeah, and my left
and
wrist,
your left wrist? What about your right shoulder,
nothing.
right wrist and elbows, fingers? So lots on the left side historically. Here we have one. From on your tummy on the floor. So I'm just going to pick, just lying on your stomach. Actually, should we do it here? You can see that okay. Should we put these lights on? But on your tummy on the floor for me. All right. That should work right. Hands on your forehead. I'm just going to do it here. Okay. I'm just going to get my hand, your feet together. Just bend one leg for me. So bend your right leg. Go lift it. Extend it. Go straighten your knee. And put it down. Do the left leg for me. Bend it. Lift it. Extend it. Put it down. Go again. Do the right one.
Go bend, lift, extend, down, go left, lift. Is that harder work on the left? Much harder work on the left. So we're looking at these two, hand there, bang, 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 bang. When she's doing it, just do the right leg first. It's all a little bit latent, but the left leg is straining a lot harder. So, to cut to the chase, I'm going to test this first. So bring your legs towards me, both legs there. So if this is the problem side, just do the left leg for me. Bend it, lift it, straighten it, and put it down. Keep your legs right over here. Do the left leg again for me. Is that hard work?
Yeah.
Much harder work, and we can see there's a lot of fasciculation going on there. This is working very hard. If I take both legs over that side, keep going. Just there, keep your body straight. Do your left leg only for me, bend it, lift it.
Oh my God, that is so much easier.
Does that feel easier?
Yeah.
Gotcha, off you go. So this again is this directional response. So we're doing the same test in 3 different positions of getting a directional response. It's happier in its bias to the left. It's less happy in the biasing to the right. Keep going. So this again, this is part of the short testing process. See, do we get a directional response? We can probably also see this with strength. Bit of live ammo here. I haven't done a full assessment, but bend your knee for me. You pull against me. Pull hard as you can. So that. Go again. Pull. Okay, so I got pretty good. Go again. Pull. And not bad. Bring your legs over here. Keep coming. No, all the way over. Keep coming. Bend the knee. Okay, pull against me hard as you can. Pull. Try again. Pull. One more time. Try again. Pull.
Oh, that's really good.
The problem with strength, and we've been doing this for many, many years with hamstring tears, with strength, with athletes. Go again, bend for me, bend, and doesn't matter how hard you work, go over there, bend, and this is a measurable response. Go bend, pull, there you go, that's got, go again, and so this is your better position. Do those again for me. So this is the left extension bias. Off you go. So it means I'm not going to test that thing on the other side again. That's a redundant test. The test I'm now looking at you is those function tests. So you're just going to do it does now. And this is how we educate the patients. Once you've demonstrated something like that, is the patient now interested?
Yes.
Yes. You worth a lot of money
No.
as an athlete? Just checking.
No.
That's good. So this would be one of the exercises that we could be doing, which would fit a left extension bias. And I've just chosen extension because you were so crappy after sitting there for a while. I had my suspicions. Okay, have a breather. Now, just stand up for me. Just stand there. Just cross the arms. Just hop on your right leg for me. Go. 1, 2, 3, 4, 5. Hop on the left leg. Go. 5, 4, 3, 2, 1.
That actually felt better.
Same, better, or worse? Better. You already don't answer me yet. I've asked the question. Did it look different?
Yes.
Good. Okay, so,
Felt easier.
and it looked easier, and that's where we're videoing it. We could record that. We can also get a number, out of 5, what would you have given it on the right first time around?
3 maybe?
Yeah, I wouldn't have. But
Maybe 2.
2.5, I'll meet you halfway. What about on the left?
1.
Okay, what would you have given it then?
3 maybe?
And what would you give it on the left?
Right. It felt about the same.
On the left side,
Yeah.
compared to before?
Yeah.
What would you have given it?
Compared to when you first did it, from like a 1 to like a 3. And the right's like just bad, so like 2.5 still.
But this again, we're getting numbers, you know, patient observation, videoing, all these can be measured. You can measure on centre of predator, force plates, all sorts of things. So, over here. Here's what we would then start doing with this. You're going to stand there. You're going to take your left leg back there, and then bring it back up. So that's an extension exercise on the left. Actually, yeah, you can probably pull the plug out. Yeah, just pull the HDMI plug out. That's all right. Yeah, just come a little bit closer. Good, coming back up. Can we all see that, guys? Actually, pop it and probably just pop it there. Yeah, put it on the plug. Put it on there. So coming back up there. So again, this is where we've got extension on the left, your weight bearing on the good leg, not problem leg. And this is a left extension biased exercise. So this is where we don't do things on both sides. We've got a unilateral problem, one side. And again, if you know which questions to ask, your whole subjective can be shortened massively. Did we ask the right questions?
Seems like it.
Seems like it, yeah. Who said stop? Keep going. And that's again, you're looking at lots of repetitions. I've got my hands on it here because don't push any further than that. That's it, coming back up. So all of this, the force vector is in this side. And one thing we have proven, that weight bearing on the affected limb is actually counterproductive. If you really want to get interested, we've been doing this now with stroke patients. We're finding that you don't weight bear on the limb to improve stroke function. Weight bear on the good limb, not the problem limb. But that's another PhD. If anybody wants it. We do stuff with transcranial MRI on this as well, to have a look at the cortical regulation. How many have you done?
Oh, thank you.
Good, do another 5 at least. And this is where you can actually educate them, talk to them while they're doing it, and they're doing lots of repetitions. Happy with that? Okay. I'll get you on the machine. On your knees, so kneeling on the machine, just go into your forearms. Keep a lordosis for me, that's it. Just pushing back with your legs, just the legs, and then bring the carriage back in. That's good. Push it back. Got it. So again, we're keeping them in lordosis, so we've got, think of our force vector here as extension, loading. If I then want to left side you, take both elbows to the left. That's good. Keep the lordosis for me. Good. If you can't walk tomorrow, let me know. It means we've found the thing you shouldn't be doing. In fact, I say that to all my patients. You're either going to be better, you're going to be the worse, you're not going to be the same. If you're the same, our threshold is higher. We've got to work a bit harder for it. But if we do stuff like this and we get a latent response, which is why you don't do things on both sides, we've documented it, we then know what it is that we did wrong. Easy. How are you going with those?
Good.
How many have you done?
8.
At least maybe 12. I've got my hand on here so she keeps that lordosis the whole time. Okay with that?
Yep.
Good. I'll give you another left extension biased exercise. Have you done Pilates before or?
Yeah.
What version have you done? Not like this.
No, the reformer.
How have you been afterwards?
Sore in my back.
Sore in your back.
Yeah.
Was a lot of the exercises lying on your back in supine and flexion?
Yeah, I found that.
There's
I heard it down here.
There's the dead giveaway. We won't do those again.
Okay.
On your knees, face me. Okay, have you done this one before?
Yeah, I
The
think so.
carriage is going to move. Don't move.
No,
Don't fall off.
Okay.
Good. There you go. Hands through there. Grip. Hands through there. Hands over. Now keep your hips forward. You're just going to pull the carriage in the side. Stop there. And then don't hit me. It's the return where I don't want you getting perturbed. Now to bias this, bring your left leg back. There we have a left extension bias.
I can really feel that.
Where can we feel that?
On the left.
On the left. And this is where we've done our tests. So we've got she didn't get worse after we did the one on the floor. That's the thing. Are they better? Are they worse? Are they the same? Certainly wasn't worse. So we're just taking the next step with this. We do all these exercises just on the left. We go back and assess. Is it better? Is it worse? Is it the same? So this is how subgrouping works. That comes down to this. And that's where you get far better reproducibility. There you go.
Good.
Good. That's an indicator I can do more. Of course, if I'm doing this with a patient, they start to get peripheralizing leg pain as they do it. I might change my mind. You're getting peripheralizing leg pain? Good.
Feels good.
Feels good. And this is it. Patient compliance correlates to how they feel doing an exercise. You give them an exercise they can't do because it's the wrong bias. A, they won't do it. B, they can't do it. C, they don't see the benefit. D, their compliance goes through the floor. Compliance with this stuff is through the roof because they see the benefit and you videoed it and there's less. There you go.
Good.
Over there for me. Now we're going online there. Crossing your arms, face me. Good. Just stand on your right leg for me and give me five big hops on the right leg. Go. 1, 2, 3, 4, 5. 5 big hops on the left leg. Go. 5, 4, 3, 2, 1. Compared to before,
Still.
still a bit heavy. Not as heavy as when we first did it.
Yeah.
And that's the big thing. You can hear it on the floor. Thump, thump. All right. So this is where we get the history from you. We've got everything happening on that left-hand side. We just do our work on the one side, which means the homework will be the same. Oh, I was exhausted now. On your back. Okay, just lying on your back for me.
On here. Or
On the bed, yep. Just legs down. In one of those studies before, we saw straight leg rows being looked at.
oh my god.
That a bit tight.
I'm not flexible.
That's neural.
Yeah.
Do you do much stretching?
No.
Good. Don't. That's pretty nasty. Straighten your knee. And
Oh.
okay, so also neural. Over our tummy. All right. So that's another assessment. So you've got a functional test, the squats, that's a structural test. Bring your legs to the left. Off we go. Bend the left leg. So this is going to be one of your homework exercises. Bend it, lift it, straighten it, and put it down. So do 10 of those for me now. Could we give her the 4-point kneeling exercise? Another one on all fours. What do they call it? Bird dog? Bird dog. Bad dog. We could do that, but we'd be moving which leg?
Left leg.
Just the left leg. How are you going with those?
Good.
Doesn't worry you too much. I've just got my hand here to make sure she's keeping that bias. As I said, this is where the strength testing, as we said before, we can measure that on hand dynamometer and find the same muscle doing the same test in 3 different positions gives a completely different strength recording. Do you think this is confusing people? Fantastic. The other people who have to get us, strength and conditioning people who have to get us too. The good thing is we can actually prove it. Okay?
Yep.
How many have you done?
10.
Pull against me. Just there. So pull hard as you can. So that's, yeah, we can still measure that quite nicely. I'm not going to bother measuring it over there. As I said, that's a redundant test now. From there, just come down flat. Sorry, where you are. Hang on, go over there. And your body. Now bring your legs there, that's it. Now if you lift your trunk off the bed, and your hands as well. So hands under your forehead.
Okay.
Yes, that's the one. Hold. Good. Do it again.
Hard.
Hold. So again, we've got a left extension here. Come up in extension. Good. And again, we can use this for upper limb as well. You know, you've had a series of upper limb, you'll be doing this as well. So lower limb function tests. These are upper limb function tests. You can still use the shoulder tests, but not from a structural standpoint. Happy with those?
And then really.
Okay.
On the back.
On your back. Yep. Come over towards me. And bit happier?
Yeah.
I can still get with the neural, but you can still get that past 90 degrees. So
Yeah.
yeah. So again, as I said, we're getting positive result by doing the one thing on the one side, and that test has been validated as well. It's not hamstring muscle. It doesn't matter what structure it is, but I'll be happy if someone says it's neural.
Yes.
It's neural, that'll do. Good. So this is where typical sort of patient presentation, which is a left neck, left wrist, left arm,
Left back.
left back, left what?
Left ankle.
Left ankle. Yeah. So more things on that side. This side will probably resolve by itself, but we do one thing first. How long has that been going on for on that side of your body?
Yes.
Years. Chronic. There we go. Have you had treatment on all the various parts?
My neck, and that's about it.
That's about it.
Yeah.
So we're still getting problems with it, which we can then come back and,
Yeah.
okay. So this is how this works. So the exercises all become specific to this direction. So you can do a lot less and we're not doing something that you get in the gym. So this again where physios are working on a much higher level than your gym instructors and your Pilates instructors, which we have to do. That's our responsibility. We have to do all this assessment first. We have to take notes because we are APRA registered and it's called law. By law, you have to take notes and show that you're doing a treatment model, not just a class or a group. But never do groups or classes as a physio, particularly if you haven't taken notes. They'll be after you. Any questions? You happy? Never repeat any of this in exam. Good. Stand up, one last chance. Actually, I'll show one more thing for you while we've got it. Out this way a little bit. On your tummy, actually spin around the other way. So I'm just going to do an exercise here. Come towards the edge of the bed. A little bit further. So hands on the bar. Push the bar down. Hold the shoulders there. Bring the legs to the left. Now, just keep your elbows straight, coming up into an arch for you. Is that okay on your wrist?
Yeah.
It's stiff. This also saves these. My thumbs after 37 years are still doing pretty well.
Yeah, I can really feel it moving.
In through here.
Yeah.
So again, this could be a lumbar thing with a radiculopathy going on. What's happening in the neck. Could a neck problem start problems in your lower limb? Ask any quadriplegic. And I've seen many of these problems down here where no one's looked there. And then you've got a whole history of the upper. You sort the upper side out and this thing resolves. Coming up slowly. Coming down. By the way, this is the lazy man's mobilisation technique. Could this be discogenic if she had a discogenic problem showing up on scan? Yeah. What about a femoral stenosis, canal stenosis, osteophyte in the canal, spondylolisthesis, pars fracture? Would any of those things fit this presentation? So that's where you've got your radiology. You can actually differentially diagnose and go radiological false positives and then treat the patient. Happy? 2 more. Last one. Excellent. Over on your back. Just relax it. Yeah. It starts to come on, but R1 is much later in range.
Yeah.
Even this one, what's the one doing? Oh, way easier. All right, this one's a keeper. Stand up, do your hop tests last. How's that group going?
Silky one.
All right, just cross arms. Do 5 big hops on the right. Before we go, 1, 2, 3, 4, 5. 5 big hops on the left. Go 5, 4, 3, 2, 1. So it's not worse. It's less thumpy than we first started, so there's better control. So there's enough to sort of give us a we got something. From a chronic problem that's been going on for years.
Yeah.
It won't change for this, all right. And you can tell by the way she's looking at those legs. Do you notice them? This person's hypermobile. There's an old dancer there. Old dancer? Couldn't half tell. But again, for someone who is hypermobile, and that's a very stiff straight leg raise. It's mural. Bingo. Don't stretch. All right. Any questions online?
Great.
Right. Yep, you there?
Yes. So I'm just trying to figure out the concept of the left-sided bias. Here we had her bending to the left side, and the left-sided hip extension was a bit weak, and then that's why we are doing more exercises on the left side bias. Are we going to avoid left side extension, or we encourage more left-sided extension?
We're going to encourage more left-sided extension. So the function on the left side was poorer than the right. Her history of problems is on the her history of problems is on the left. So this is where extension on the left only is what the research is sort of showing and backing up all the way along, rather than doing things on both sides. So we're talking way above the concept of weakness. We're actually looking at function. So that's where we can get a much quicker program with the predictors behind it. And as I said, this is not just an isolated one structure, it's all on the left-hand side. So they're the big ticket items to look for when you're taking a history. Can I find top to bottom, left and right, take a full body chart. Don't just circle around the knee and nothing else. And then look for this potential for asymmetry. You'll find it there in 80% of the patient population.
Okay. Just to make sure I understand clearly.
Yeah.
It's more like we do a test, we find the deficit, we find the impairment, and we call it like certain bias, and we just train more of the impairment, are we?
Yes. So you train them in that bias, yeah. And this is where the subjective is critical. You've got to do a very good subjective first. So by the time you take your subjective, do you have a directional bias hypothesis? As I said, on that 4-point algorithm, the E, A, and T, you should have a hypothesis, and your task then is to prove or disprove that hypothesis.
Okay, thanks so much. Greg.
And then you can go back to structure. But once you get into chronic, this is the model to follow, which, as I said, it's got huge evidence now behind it. And hopefully, we'll get this into more practice. We'll wind back the chronic problems out there, which I won't do because I'm getting old.
Okay.
Oh, yes.
I understand the directional preference with the lower back issues.
Yep.
But I'm kind of confused about how that relates to like one-sided issues. Like, let's say it's just like a knee and a shoulder, no lower back pain. How would you know which direction then? So let's say it's left-sided. How would you know if it's like an extension or flexion or that type of thing?
Again, it comes from the subjective. You know, have they specifically had an injury or a trauma? I've been working with athletes 37 years. Most athletes are one-sided. And this is another study we did through British rowing with the Olympic squad many years ago, was actually looking at the Olympic squad and actually doing non-sport specific training, did training not specific to rowing, and they improved on functional and on functional scales, on the ergo, and also patient-specific function scales. So that hasn't been published, in fact, because that's a very valuable paper. But this is the thing of sport, is very commonly one-sided.
So then in that way, when you're biasing like flexion or extension, how do you know which one to do? Or do you just choose one and see if it doesn't work? Or it does work and then...
No. That's where
I think I missed that bit.
that's all right. This is where taking good history is critical. You know, it's as I said, going through and finding ags and eases. Everybody should be asking ags and eases, so you actually get a clear picture of aggravators and easing factors, and that goes alongside also the trauma factors. So you're not guessing. There's no guesswork involved in this. It's very clear. You may not get all the ags, but you certainly get all the eases, or vice versa. You may not get ags and eases, but they've had an extension trauma. We don't want to work with the military. Explosion traumas. Somebody's turned away from the device has exploded, they've gone into extension, being thrown and landed flat on their face. That's an extension trauma. So this is where being a good historian is absolutely critical. Yeah. Get a toe popper, an anti-personnel device that blows off your foot. They're not designed to kill you, but they make you more of a problem than they bottle. Forward, nasty. You end up with military. We've got any military physios online? They know all about these things. Does that sort of help?
Yeah, okay, yes.
Yeah. It's taking the history. That's what we sort of go more into. Very, very good subjective history.
Sorry, just one more question, Craig.
Yep.
In terms of the professional athletes that you've worked with,
Yep.
how frequently would you do this training with them in conjunction with the other training that they do for their sport?
This is where you become a control freak. You've got to do it right through all their strength and conditioning program. So you take their strength, and you can do it. We have done it. So we did it with GB rowing. That's one of the squads. We've done it with quite a few of the English Premier League teams. But you've got to apply the bias across all their training. So you can do a strength and conditioning program with a bias, absolutely. And that way you've got consistency. Otherwise, you've got conflict. You're doing this with them, and then you're doing something different, it'll unravel. It'll unravel pretty quickly. So this is where that strength and conditioning program, and their other training as well, has to be aimed to improve function and has to be consistent across the board. And then you'll get better athletes. Which at the moment we're seeing a lot of injured athletes, and it's because they're actually doing the opposite to this. They're doing things on both sides, training for the sport, and their sport is their trauma. repeated movement like your tennis players. Does that make sense?
Yes, thank you.
Gotcha. Anybody else? Good. All right. Hope that got a bit of interest going. Any questions? Happy with that?
Do you ever do exercise training? Ever? Is there ever, like, do you get to a point where you do train bilaterally, or is it generally there's always like a unit?
Every patient is different.
Okay.
And there's a thing with that process of getting patients to a point where their symmetry is equal. And then what we do and can do is we introduce your bilateral. And if you introduce bilateral and the symmetry index is maintained, then yeah, you're doing both sides. Then you get the next stage from that, you then introduce the opposite direction. You know, if she's been doing lots of extension, you now introduce flexion, and that was that time frame that I gave you before that we've been modelling. We test her with flexion exercises, and if we find, yeah, she's still pretty good, there's no immediate response, there's no latent response, then they're okay, you know, they're getting back to doing everything. But then the other side, you introduce flexion and everything falls apart, they're not ready for it, they may never be ready for it. I've got Premier League players where they're one bias on one side in one direction till the end of their careers. But they'll earn a lot more money in the meantime, because as soon as you take them out of their bias, their functional tests would deteriorate. Why? That's your PhD. But we're doing some of this, you know, we don't know the actual why. We know it's definitely neurological. We know it's definitely subcortical. We know it's definitely measurable and highly reliable to 0.87 kappa, yes. So, yeah, plenty of work to do on these things. Okay. Does that answer your question?
Yeah.
Yeah. Okay.
Everyone's different.
Yeah, they're all going to be different. And that's when you get to the point where they're working, you can test them, they deteriorate, boom, bring them back, and then that way you get them out playing quicker for longer, and eventually it may come back, it may not. It may not. Our job is to get them there and keep them there. It's possible. Don't just treat symptoms. That's the bottom percent. All right. Thank you very much. Thanks, guys, for coming along. Hope you got something out of that. We can put this up. Where are we going to put it up? Everywhere. All right. We're going to put the links up to some of the research everywhere. Actually, some of the 2025 research we didn't put up there. We just had a course in Singapore last weekend with Lun Chong on that course, helping out, which was great, and we've got him again in a couple of weeks' time. So very strong research faculty up in Singapore at the moment. Get the Australians back here on it too. Okay. Thanks, guys. You can go to bed now. We'll read up the research. Thank you, Dave, for organising this. And yeah, it was good. Good to have people online. Works well. Thank you very much.